Hi, my name is Anat Galor. I'm a cornea specialist and with a focus on ocular surface disease at Bascom Palmer Eye Institute, University of Miami. And I'm talking to you from Bogota, Colombia. And my talk was about Meibomio gland dysfunction. So if you weren't lucky enough to be in Bogota with me, because it's a beautiful city, my 3 tips from my talk were: 1, that Meibomio gland disease is very common and you shouldn't go chasing it. But in patients who have dry eye symptoms and you've looked at other things like tear insufficiency, inflammation, Sjogren's, and you're left with Meibomio gland dysfunction as a potential cause of symptoms, it's important to treat it, and you need a step-ladder approach to treatment. So my step-ladder approach is number 1, treat any potential obstruction with any combination of lid hygiene that you like. And there are both over-the-counter products, or patients could just use hot compresses and clean the eyes with a washcloth. Clean one. But overall, there have been many studies that show that if you clean your eyes with some combination once a day, you feel better. So it's a good place to start. If that doesn't help, the next step is to target inflammation. And I generally do it with topical or oral antibiotics that have also been shown to help inflammation, like doxycycline or azithromycin. They're generally well tolerated, and I use them mostly episodically. So for doxycycline, 1 month on, and then I reevaluate. And if that doesn't work, then I start thinking about other potential contributors like hormone dysfunction, although we have less data on androgens and how they affect Meibomio gland disease, and other things like Demodex, which can be found in many people, but I really only treat aggressively if I've tried my other things. So that was point number 1. It was a long point, but it's a point. The second point is that we should start thinking about MGD more in the dental paradigm, with telling patients on daily lid hygiene, but considering having them coming to the clinic every 6 months for a deeper cleaning. And there are many different agents that you could do deeper cleanings with, but the one I use is IPL, or Intense Pulse Light. There are many different machines that do it and different protocols, but the idea is you treat the cheekbones, you try to get a homogeneous uptake where you get a little bit of red, and I repeat the treatment for 3 times about every 1 to 2 months. Some people couple it with manual expression at the time of treatment, others with topical steroids after the treatment. But overall, studies have shown that this can improve dry eye symptoms and reduce dry eye signs, and there's an improvement in inflammatory markers on the tear film. And as an extra bonus, the skin looks beautiful, so patients are happy. But there are other agents out there like LipiFlow and Nuclean and Blefex, and we don't have a lot of head-to-head data or actually good data on each individual one. But my third point, and most importantly, is that none of these treatments are going to hurt the patient, and that's good. So you have time to do a little trial and error. You tell patients dry eye symptoms are generally chronic, and our goal is to reduce them with whatever works until they get good enough. And it's important to keep these tips in mind: lid hygiene, in-office treatments, potentially treat inflammation, and then potentially address other things like hormones or Demodex when you're trying to approach the MGD patients. And the good news is while you're trying to figure out, generally these treatments have an excellent safety profile, so you're not going to hurt the patient, which is, again, the mission. So thank you for listening to my few tips, and we miss you here in Bogota.